Hello, I'm Dr. Antoni Wheeler, and I'm telling you everything that you need to know about pathology. What's happening in this image? It's an MRI. Can you see the extreme brain lesion? Okay, great job. We're going to be discussing this in our lecture today on central nervous system tumors pathology. This is covered in your book, Medical School Pathology and Step 1 Review. Hopefully you've been using it, getting all of that information to ensure your success on Step 1 and on Medical School Pathology. The foundation is here, everything that you need to know. So we're going to be discussing CNS tumors. Central nervous system tumors are abnormal growths that involve the central nervous system. And here's a very complicated image showing various CNS tumors such as glioblastoma, anaplastic astrocytoma, diffuse astrocytoma, anaplastic epidemioma, and anaplastic oligodendroglioma. Now, you don't need to know some of these details, but I'm going to be sure to inform you on your must-knows, right? For example, GFAP. Know that that is a CNS tumor stain that will highly likely show up, okay? But don't worry, I'm here to help you. I want to see you win, so I'm going to point out all the things that you need to know. So let's talk about CNS tumors. The types of central nervous system tumors that you must know include Glioblastoma Multiforme, Meningioma, Schwannoma, oligodendroglioma, Pilocytic tumor, which is a Pilocytic Astrocytoma, a medulloblastoma, epidemioma, and craniopharyngioma. Now I know that's a lot of gliomas and omas, etc. But don't worry, we're going to tease out the differences to make sure you got all of the things that you need to understand. First off, approximately 50% of central nervous system tumors are metastatic, right? They don't even come from the brain itself. If that was the case, they would be primary. But a lot of these are secondary. How many are secondary? Well, about 50%. That means the other 50% are likely to be primary, right? Metastatic tumors to the central nervous system typically appear at the gray-white matter junction as a number of distinct lesions. Common sources of metastasis to the central nervous system include cancers from the kidney, breast, and lung. Primary central nervous system tumors are categorized based on the cell type that has given rise to them, which includes astrocytes, meningothelial cells, ependymal cells, oligodendrocytes, and neuroectoderm, right? In adults, primary central nervous system tumors are typically supratentorial. And in children, primary central nervous system tumors are usually infratentorial. Now, this is important. The three most prevalent central nervous system tumors in children are Pilocytic Astrocytoma, epidemioma, and medulloblastoma. Primary malignant central nervous system tumors rarely metastasize. And primary malignant central nervous system tumors are locally devastating. Here we have representative sections from histology of a patient that had a very complex tumor that was actually mimicking another one. So for all intents and purposes, you don't have to know this, but just FYI, Lin 2A stained this here tumor that maybe some neurosurgeons or pathologists that are going into neuropathology would like to know. So to satisfy your curiosity, this is a embryonal tumor with multi-layered rosettes. But for testing purposes, you definitely have to know about this. This is bread and butter right here. Glioblastoma multiforme. Gotta know it. Glioblastoma multiforme is a malignant high-grade tumor of astrocytes. Now take a second to appreciate this H&E section of a glioblastoma multiforme. Take note of that central necrosis surrounded by pseudo-palisading of tumor cells. That's a classic lesion. You will see it, I guarantee it. Glioblastoma multiforme is the most common primary malignant central nervous system tumor in adults. And we could see that clearly on this image here, this WHO grade 4 MRI. WHO means World Health Organization, by the way. Regarding glioblastoma multiforme, the cerebral hemisphere is where the butterfly lesion associated with GBM typically happens, which often spans the corpus callosum that develops. Histologically, GBM tumor cells are gliofibrillary acidic protein positive, right? You know that. They're GFAP positive. And they are characterized by areas of necrosis, like you saw, like you know, like you remember, areas of necrosis surrounded by proliferating endothelial cells that are malignant. That's glioblastoma multiforme. And it has a poor prognosis. Here we can see axial post-contrast T1 and T2 weighted MRI showing a IDH mutant frontal lobe glioblastoma with sparse enhancement. Look at the size of that lesion. Do you understand why they can be devastating, right? Here we have more imaging of a glioblastoma multiforme, this time in the frontal lobe of a patient. And here we have some histology of a glioblastoma multiforme. Now this is extremely high magnification, but what it is showing is the multiple mitoses. You can actually see that indicated by the white arrow, and multinucleated cells indicated by the black arrow. Now let's talk about another lesion that you must know. Meningioma, okay? Meningiomas are benign tumors of arachnoid cells. And here we can see an MRI of a meningioma. They have a classic distinct look, which makes them great for test fodder. Meningiomas are the most common benign central nervous system tumor in adults. Meningiomas are more common in females than in males. Meningiomas may cause seizures due to the tumor compressing the cortex without invading it. And you can imagine how that brain tissue would be getting compressed, right? Clearly based off of this image. The radiology of meningiomas typically show a spherical mass linked to the dura. And the histology of meningiomas is characterized by a commonly tested buzzword feature known as a whorled pattern or psammoma bodies. You'll see that within meningiomas, I guarantee it. And here we have gross pathology from an autopsy. You're looking at a skull that was removed. There's dura on it, and you can clearly see the round spherical pedunculated lesion that we define and diagnose as meningioma. And here we have a micrograph of a meningioma showing that characteristic whirling pattern. And here we have more histology showcasing that whirling pattern. Now let's talk about another tumor that you must know, because this is highly tested too. Schwannoma. Schwannomas are benign tumors of Schwann cells, and they have a classic pattern as indicated in this H&E image to the right here. There will be Antoni A fibers and Antoni B fibers, okay? Schwannomas may involve spinal or cranial nerves. In the head, the vestibulocochlear nerve at the cerebellar-pontine angle is the most usually involved by schwannomas. And they have a classic stain that's used to visualize them that even at your level you must know, and that is S100, okay? S100. The histology of schwannomas is characterized by spindle cells that are S100 stain positive. Bilateral schwannomas are often seen in patients with neurofibromatosis type 2. Here we have the histopathologic image of a schwannoma. Can you point out the Antoni A and the Antoni B areas? Here we have a subcutaneous schwannoma. And here we have intermediate magnification micrograph of a schwannoma. Take a look at the acellular Antoni A area. Can you see that? You recognize it? Regarding schwannomas, take a look at this image. The Antoni A area of a schwannoma with a verrucate body, indicated by that circle there. That's another buzzword that's a giveaway for schwannomas. Verrucate bodies. And here are a number of H&E sections that have various patterns for schwannomas. Be sure that you can recognize Antoni A and Antoni B and verrucate bodies, because that will come up. And just for completion, please make sure you can recognize the Antoni A areas and the Antoni B areas. Also, remember, they stain positive with S100. Now let's talk about oligodendrogliomas. These are malignant tumors of oligodendrocytes. Here we have the radiology of an oligodendroglioma indicated by an MRI. You see that circled lesion there? The radiology of oligodendrogliomas typically show a calcified tumor involving the central nervous system. Oligodendrogliomas typically affect the frontal lobe, and they may cause seizures due to mass effect. Here we have the classic histology of a oligodendroglioma. Now these typically have a buzzword fried egg appearance. It's almost pathognomonic for this. Can you imagine this, right? You see the fried eggs. If you look very closely, I know there's a lot of cells here, but you should see some blue nuclei surrounded by pale white. Those are the quote-unquote fried egg appearance of the oligodendroglioma. And here we can see some of the characteristic small branching chicken wire blood-like vessels or wire-like blood vessels that are present with oligodendrogliomas. Now here we have various sections from an anaplastic oligodendroglioma, but it's highly unlikely that you'll be tested at your level for that. But if you're going into pathology or neuropathology or some sort of neurosurgery, keep this in your back pocket. It'll make you look smart when you're rounding or looking at H&E slides or discussing something with your attending. So kudos to you. Now let's talk about pilocytic astrocytomas. A pilocytic astrocytoma is a benign tumor of astrocytes. Pilocytic astrocytomas are the most typical central nervous system tumor in children. Pilocytic astrocytomas tend to develop in the cerebellum. And here we have imaging, an MRI brain scan showing a recurrent postoperative brainstem cystic polycytic astrocytoma. You should be able to point out the lesion in both of these images, A and B. Okay? And keep in mind that the radiology of pilocytic astrocytomas typically show a mural nodule and a cystic lesion seen on the imaging. The histology of pilocytic astrocytomas shows eosinophilic granular aggregates and Rosenthal fibers, which you will be asked about. That definitely shows up. Rosenthal fibers for pilocytic astrocytomas. And specifically, those Rosenthal fibers are thick eosinophilic processes of the astrocytes. The tumor cells of pilocytic astrocytomas are GFAP positive, okay? And here we have a characteristic H&E stain for a pilocytic astrocytoma, as well as on a non-contrast CT scan. And here we can see the characteristic bipolar cells with their long hair-like processes of pilocytic astrocytomas. Now let's discuss another commonly tested condition known as a medulloblastoma. Okay? A medulloblastoma is a malignant tumor originating from the cerebellum's granular cells. So it comes from the neuroectoderm. Medulloblastomas typically occur in children, and they have a propensity to grow very rapidly. Here we have the histology showing a medulloblastoma with its characteristic small, round blue cells. And take note that there's a buzzword associated with this lesion known as Homer-Wright rosettes, because those are typically present with this lesion. Medulloblastomas are characterized by a poor prognosis. And here we have a figure that shows various images of medulloblastoma. It's a CT brain scan of a child with medulloblastoma and the resulting hydrocephalus. And here's some histology of a medulloblastoma, including immunohistochemistry staining with beta-catenin. Beta-catenin is used to stain medulloblastoma. Now let's talk about epidemioma. Epidermomas are central nervous system tumors that are composed of malignant ependymal cells. Epidermomas typically affect children, and they most frequently occur in the fourth ventricle. Hence, they may be accompanied with hydrocephalus. And the histology of epidermomas classically show perivascular pseudo-rosettes. Perivascular, hence around a vessel, pseudo-rosettes, right? And you can clearly see that in this accompanying image. Again, we have another H&E section of an epidemioma. Do you see that classic features, especially in A? Now let's talk about a craniopharyngioma. Craniopharyngiomas are central nervous system tumors that develop from Rathke's pouch epithelial remnants. In children or young adults, craniopharyngiomas typically manifest as a supratentorial mass. And craniopharyngiomas have the potential to compress the optic chiasm and cause bitemporal hemianopsia. Here in the CT scan, you can see where a craniopharyngioma commonly occurs. And they typically have this calcification that's classically associated with them. And with that, you finished a highly tested lecture. So congratulations to you. I applaud your efforts. You're doing great. You're studying and you're getting all the information down packed. You got your book. You've been checking the website for updates. You are on point. You're sharp. You're ready. I look forward to your success. If there's anything I can do to help you, to support you, let me know. If you have any questions, comments, or concerns, let me know. I'm here to see you win. Till next time, take care.